Welcome everyone, and thank you so much for joining our webinar today. Today, Dr. Jennifer Portz will talk about digital health and palliative care. Just a couple of items before we get started. We ask that you submit all your questions through the Q&A feature, which is a button at the bottom of your screen. If you type in questions, we'll be able to answer those periodically throughout the webinar, and we'll also have time at the end for Q&A. If any questions that come up are more technical in nature, like if you're having trouble hearing, for example, we ask that you please use the chat feature, and we'll do our best to answer all of those as well. All of our attendees today are muted and video cannot be turned on, and our panelists include Dr. Christine Ritchie, representing the PCRC Executive Committee. And so I'd like to turn it over to her and ask Dr. Ritchie to please introduce our speaker for today.
Wonderful. Thank you, Naomi, and greetings everyone on today's webinar. We are so delighted to have with us today Dr. Jennifer Portz, or Jenny Portz as many of us call her, who has a PhD and a Master's of Science in Social Work, and is an assistant professor at the University of Colorado School of Medicine and also an affiliate investigator with Kaiser Permanente, Colorado. Dr. Portz is one of those rare and wonderful folks who is both a social worker and also a palliative care researcher, and is currently funded by a highly competitive Paul Beeson K76 Leadership Award in Aging. She earned her MSW from Boston College and her doctorate from the University of Denver. And her research really focuses on that interface between patient and family-centered serious illness care and digital health interventions, and how to make these interventions family-friendly and particularly relevant to older adults with serious illness and their caregivers. We're very lucky to have her talk to us today about palliative care digital health. And as she'll also tell you, she also leads our palliative care digital health special interest group within the PCRC. And through both those initiatives is really sort of spreading the news about how digital health is a relevant part of palliative care provision and palliative care research. So thank you, Jenny, and we look forward to hearing from you today.
Great. Well, thank you, Christine, so much for the introduction, and thank you, PCRC, for inviting me to speak today. I'm very excited to share sort of our progress on the Digital Health Special Interest Group and talk to you about some of the exciting work that we're doing today. I also want to thank the many funders who have supported me specifically, but are also supporting this work related to digital health. Particularly the PCRC. I'm currently a 2019 pilot awardee through PCRC. So special thank you to NINR for supporting junior investigators like myself and providing that resource to us. So many of you are probably wondering, what is this Star Wars title that I'm using here? And, as many sort of tech nerds like myself are, we grew up loving Star Wars. So it just felt like a really fun title and a fun way to sort of talk about what's going on in digital health today. And so this is me as a young kid loving Star Wars back then. But let's also be honest that Star Wars has a lot of technology. So it seems like a great way to talk about how we're currently integrating technology into the palliative care space. So let's get this story started. A long, long time ago in a galaxy far, far away, we have a force awakening. So what is this force? What is digital health? I'm going to start off with a brief definition of what I'm actually talking about when I say the word digital health. I want to introduce you to the Jedi, who are the PCRC Digital Health Special Interest Group, and what the kind of work they are embarking on currently. And then we'll talk a little bit about the challenges that we're facing in the digital health space, and also sort of a recruitment method to get you to join our efforts. So what is the force? What is digital health? And there's a lot of terms that sort of circulate when we're talking about technology in the healthcare sphere. And health IT, or HIT, refers to the actual systems or solutions for sharing, storing, and retrieving this kind of information. So these are the specific types of tools that people are using in the healthcare setting. Health informatics is actually the interdisciplinary science that is looking at best practices in design, development, and adoption of HIT in healthcare setting. So we have the actual tools, HIT, and the science, health informatics. Now, digital health is a fairly newer term that's really a broad scoping term that includes all the categories such as mobile health, health information technology, wearable devices, telehealth, telemedicine, and personalized medicine. It really is a broad, all-encompassing term for any kind of digital technology that is targeted towards improving health or health services. So, thinking about all of these tools, we have lots of lightsaber options. Some people like to use red lightsabers and some people like to use blue lightsabers. And so here you get to pick your own, whether it be mobile applications, sensors, social media, text messaging programs, artificial intelligence, machine learning, virtual reality, electronic health records, patient portals, e-prescribing, telehealth, and telemedicine. So these are some of the areas that people are currently working in across many sectors, but trying to integrate these particular types of digital health into palliative care. So to give you some context, and maybe I'll move, to give you some context, you can't see the edge of the graph, unfortunately, but you can see that the growth of cell phones and smartphones, the majority of Americans do currently own and use cell phones, and the mass majority of those are actually smartphones. We're starting to also see increases, these similar trends in tablet access as well as computer access. We're actually seeing slight decreases in people using broadband because people are accessing the internet via their mobile devices rather than using hardwired broadband. So these access to mobile tools, tablets, mobile phones is really a sort of unique and exciting way to collect data from patients. It's also a very exciting way to support them in a new way with a device that they sort of keep in their back pocket or their purse at all times. There's been obviously a huge increase in mobile and digital health over the last decade. You can see the curves here for both publications related to mobile health, but also the funding towards better understanding mobile health. You can see in the first graph that the number of funding, the funding reported here is specifically in the United States and the United Kingdom. You can see that it's exponentially grown, particularly in the early 2010s to 2014. And you can see the global publications for mHealth have also drastically increased. There was a recent publication submitted or published by the Journal of Medical Internet Research, JMIR, that looked specifically at publications that use the word digital health, not mobile health, and these trends are also increasing for the word digital health as well. We also have the rise of a digital health consumer. So we see every year that patients and caregivers are much more likely to use technology to support their health. You can see that there's increases between 2016 and 2018 for people using a variety of mobile health tools to manage their health, such as websites, electronic health records, wearable technologies, and also doing remote consultation. That growth is pretty standard. We're also seeing that people are using mobile technologies and preferring to use mobile technologies to communicate with their health providers. So increased use of email messages through patient portals, as well as contacting or communicating with providers via video conference or telehealth format. We also have a new consumer, not just the patient, but also looking at caregivers. According to the Pew studies, we see that caregivers are much more likely to actually access technology tools or digital tools to either manage or get information about health of themselves as well as health for their loved ones. So caregivers, 39% of US adults are caregivers, and many of them are using this technology to support themselves as well as their loved ones. So we are using mobile health solutions, not just for patients, but for family caregivers as well. So let's go ahead and meet these Jedi that I've been talking about. And let me introduce you to the PCRC Digital Health SIG. We were formed last year in March 2019 at the PCRC in-person meeting here in Denver. I want to give a shout out and a special thank you to the SIG co-lead, Carla Washington, who is also a social worker and a palliative care researcher at the University of Missouri. She also studies mobile health solutions, particularly for family caregivers in the setting of cancer. And she has done a lot of work in sort of creating this SIG as well. It's been a lot of fun. We have 53 members currently. These are primarily academically affiliated investigators. However, we do have a few industry partners that are also members of the PCRC and part of this SIG that are really interested in developing particularly web-based tools to support end of life. We do have a very interdisciplinary membership. We have obviously social workers, physicians, nurses, and you'll see that as I start presenting some of the information and the work that people are doing currently, but that it is really a multidisciplinary group. The reason why we created this SIG was because technology is moving so quickly, and it can be really hard to figure out who is doing what and what kind of technologies are people interested in using, and what do we know about these particular types of technologies. And so we thought the SIG was actually a really good way to figure out which shops are focusing on mobile apps, which ones are focusing on telemedicine, where is that alignment across the country, and have a much better idea of where the resources are to actually leverage these different types of technology tools as well. So over the last year, we've been very busy, and we started again at the in-person meeting last year at PCRC. We then had a follow-up meeting at AHPM to talk about, well, how can we get this SIG rolling? How can we get this going, and what do people really need, and how can we leverage this SIG to support people's interest in digital health? And so we started off in October with our first SIG-specific webinar that focused on mobile health generally speaking, and that was presented in October. We also did 2 symposium submissions where we had SIG members participation in symposiums. We presented, or we applied to both GSA and AHPM. Unfortunately, we're not accepted to AHPM, but that doesn't stop us. We're going to try again. But we were able to get a great presentation at GSA talking about innovations for family caregivers in palliative care setting. Did I hear someone? No? Okay. So then we also maintain a Google group discussion board, and on this board, people ask questions and provide resources. But one of the major things that we did was actually highlight specific SIG members, which we labeled the digital dynamos. And I'm going to introduce them to you in just a second. But these digital dynamos are some of the leaders and emerging leaders in the digital health space that are trying to best integrate these innovative technologies with palliative care. So let's start off with one of the most common mobile health solutions is telehealth. We already know that in sort of the chronic disease management or primary care setting that telehealth does produce positive health outcomes. It is not necessarily superior to usual care, but we do see that there is that they do produce positive health outcomes. It's safe to deliver, and people are satisfied when the telehealth intervention is easy to use, and they do like the convenience that it saves time. So we do know that telehealth offers this sort of unique opportunity to increase access of services, and that people are pretty satisfied with those services. There is less evidence in palliative care specific telehealth. The specific outcomes for telehealth in palliative care currently are mixed. Specifically on caregiver outcomes, Barbara Head out of the University of Louisville conducted a systematic review a few years ago. She is also a SIG member, and looked at caregiver outcomes for telehealth, and we don't really quite have enough evidence to show that there are improved outcomes for family caregivers. However, there are many current clinical trials currently underway for using telepalliative care, specifically in the areas of heart failure, cancer, and in cancer that includes advanced cancer, lung cancer, and adolescent cancer, a rural dialysis telehealth project, and also telehealth projects for pain. Most of these studies are being led by what I'm calling the PCRC Master Jedi. You would know these multi-site trials that are well integrated into the PCRC infrastructure, and so we will start to see efficacy outcomes for these telehealth interventions, specifically in palliative care. We also have some junior investigators, specifically Caroline Stevens at the University of Utah, who's looking at telehealth systems for improving access to palliative care in nursing homes. And the Journal of Palliative Medicine recently published a top 10 tips for the telepalliative care. And this again was published with many co-authors of the Master Jedi who are experts in this area. And I think two of my favorite tips that they provided in this article was they say that telehealth can be used to increase access to palliative care. And there is a need to increase access to palliative care. We have staffing shortages, and there are many people that still cannot access our palliative care programs. And so this is a unique opportunity for us to increase access. And the other tip that they provide, which I think is quite realistic, is that it requires rigorous and careful planning to strategically implement a telehealth intervention in palliative care. And so I highly recommend going and reading that article if you're interested in learning sort of best lessons learned in the telehealth space. There is even less evidence for telehealth in hospice care. However, there is a clinical trial currently underway for pediatric hospice in Nebraska. My team actually just completed a non-inferiority study comparing the face-to-face hospice reauthorization visits with the video versus video conferencing for the reauthorization visit. And then we also have V from Weill Cornell, who I'm going to introduce in just a second, also using a multi-component symptom management system within hospice. So we'll also be seeing some new exciting evidence to support telehealth and mobile health in palliative care and hospice settings. And so our first Jedi, Yoda's my favorite, so I just put him first. And V. von Keinkel is a physician and a palliative care researcher at Weill Cornell, and he is one of the leading voices in the use of technology, specifically in hospice settings. He recently published two pieces, one on the potential benefits of using technology in the hospice setting. He recommends 4 specific areas that it can be utilized to conduct virtual visits, also tracking relevant information from people's homes, and also education for patients and caregivers. But there are lots of opportunities to also include sensor information to keep patients safe in their homes. And so he's doing quite a bit of exciting work there. He also conducted a qualitative study with caregivers about their perceptions of using mobile health in the hospice setting. He found that the majority of those interviewed were receptive to using technology to provide hospice services in the home, and that they were interested in using technology specifically for communication to improve patients, access to patient care information, education, and also updates from their healthcare team. Our next Jedi is Dr. Tammy Sommers. She's a clinical psychologist at Duke, and she focuses on behavioral interventions for pain and symptoms using mobile health solutions. She recently published a non-inferiority study looking at behavioral cancer pain intervention and comparing in-person versus video conference. Again, it was a randomized non-inferiority trial with cancer patients. She looked at the mobile health pain coping skills intervention versus the in-person version. She actually found that the mobile version was actually had greater feasibility in terms of its acceptability and the feasibility rates, and that there was similar burden across both groups in engagement and acceptability. So there was, although it was a pilot study, there was non-inferiority also in the outcomes that they collected at post-treatment, including pain, both severity and interference, psychological distress, physical well-being, and self-efficacy on all of those outcomes except for physical symptoms. So this is a regular theme that we're going to see, is that there is a lot of pilot work suggesting that telehealth and other mobile solutions are very feasible, they are acceptable, and they are in some cases usable. However, we don't necessarily have the efficacy data or the effectiveness data to show that these interventions improve health outcomes. So then we can also move into mobile applications specifically. So these are the software, the pieces of software that are downloaded onto your mobile phone and have the little icon, and you get the alert that says update every once in a while that actually goes onto your mobile phone. And so my team actually conducted a scoping review of palliative care specific mobile applications in 2019. We looked at both the academic literature and commercial apps available in app stores like iOS and Google Play and Android Google stores. So we identified 9 research apps and 22 commercial apps that were specifically targeting palliative care topics. We found that the majority of them were focused on symptom management, decision-making, things like advanced care planning and end-of-life planning, as well as grief. The research apps actually specifically were disease-specific, primarily connected to clinical services, and they targeted patients. The commercial apps that we found had much more flexible functions for multiple symptoms or multiple conditions, so they were very rarely disease-specific, like heart failure or diabetes. They had an option where you could choose multiple symptoms or illnesses. They were freestanding from clinical services, so that they rarely were prompting clinical intervention in some way, and they often targeted both patients and family members. Another one of our SIG members, Soumya Maglani from the University of Pennsylvania, also found similar findings when she did a systematic review in 2018 and had a hard time finding patient and family caregiver facing apps specific for palliative care. So there's a growing need for these mobile applications. So while we're talking about mobile applications in palliative care, it seems very fitting to talk about Dr. Arif Kamal, who is probably one of the biggest leaders in this area of generating mobile applications in the palliative care setting. He's a physician at Duke and was recently named one of the most influential leaders in hospice and palliative care by AHPM. And his focus of research really is on the integration of technology with palliative care. And much of his work right now has been focusing on the usability and efficacy of palliative care specific mobile applications. He recently or last year published the findings for the PC4Me mobile application, which is a mobile application that is promoting the patient's consultations with their palliative care team. So he was finding that that often cancer patients were coming into the clinic and they were meeting with their oncologist, but then they would no-show on their palliative care service, their palliative care visit, maybe not knowing that palliative care was different from oncology or for various reasons. And so the PC4Me app is a app that helps increase patients' knowledge about what palliative care is. They also did a randomized active control trial that looked at the use of the PC4Me mobile application versus well-known online resources. They found that PC4Me was not only usable, but it increased patient self-efficacy and knowledge, and that it actually decreased no-show rates during the study period. He's also creating and testing the usability and efficacy of the extra layer of support, which is a shared decision-making mobile application for patients and families recently diagnosed to improve health decision-making with their oncologist. And also the hospice preparation and engagement app, which is the PC4Me version for hospice specific. So lots of interesting work in terms of finding that these are usable, but much more is needed in terms of finding out whether or not these mobile applications are effective in improving our health outcomes. I also just wanted to note that there's a lot of work being done, not only in palliative care specific space, but also for mobile apps with for people with cognitive impairment. And so there was a recent study in 2019 published where they identified 24 studies of mobile applications specifically for people with cognitive impairment. While the outcomes were mixed, the majority of the studies did show that there was an improvement in health outcomes such as cognition, function, mood, and quality of life. So there's also an emergent science, not only in palliative care, but also in sort of the cognitively impaired and dementia space. Mobile applications are not only for mobile applications that are like in your back pocket or at home, but they're also being used in a clinical setting. So we're seeing increases in the use of tablet-based assessments while people are waiting for their visits to take place. And so our next Jedi Master is Dr. Janet Van Cleve, who is an oncology nurse from NYU. She focuses on symptom science and mHealth, and she recently developed the Electronic Patient Visit Assessment, or the EPVA, for head and neck cancer. It is a tablet-based assessment for patients to complete while they're waiting for their visit, and takes under 10 minutes to complete, and patients are allowed to report 42 symptoms and 17 function limitations that can potentially help identify triggering or problematic symptoms among this population. One of the things that is incredibly impressive, I think, of her work is that her and her team were rigorously developed this EPVA. They used a think out loud iterative process that allowed for them to first develop the assessment, but then also use patient feedback to address any potential usability issues. So as they were going through this process, they asked patients about what they thought, how they could make the assessment better, and they were able to refine very specific things, including touch sensitivity of the tablet, customized error messages, and resolving bugs that really were bothersome and troublesome for patients to complete the assessment in a timely and helpful manner. They also looked at the usability of the EPVA, and it was highly acceptable by patients, and people were very satisfied on the completion of the assessment. And they also looked at the acceptable reliability and validity of the tool, knowing that they are collecting valid and reliable symptom data for that clinical visit. In addition to our mobile apps and our telehealth systems, we're also looking at how electronic health records and big data can be leveraged to improve palliative care services. And so our next Jedi is Natalie Ernkoff. She is a postdoctoral fellow at the University of Pittsburgh. She studies how systematic identification of patients with serious illness can allow palliative care researchers and clinicians to test and implement new models of care. She also recently published an article looking at the electronic health record phenotypes, where they developed an EHR phenotype specifically for end-stage cancer. And they found that this was a promising method for identifying patients, and that some of their future directions should really look at identifying high and low palliative care need, rather than lumping everyone into one pool. And so I think there's a lot of work being done right now in terms of using electronic health record phenotyping, as well as machine learning and artificial intelligence, to identify patients who really need palliative care services. And I've listed here some of the people that are doing interesting work in this space, and feel free to click on those links and learn more about their work. I also know that the PCRC recently received an admin supplement to look at the ethical considerations of using AI in palliative and end-of-life settings, and so they'll probably be releasing some information about things that we need to consider as we move forward into this AI space. So there's not just tools for patients. There's also a huge need for tools for family caregivers in palliative care, right? Palliative care, we don't just focus on the patient, we also focus on the family. And so our next Jedi is Dr. George Demirius. He is a professor at Penn, and he is on the forefront of informatics and healthcare. His focus is on the transformative role of technology on older adults and their families, particularly in home and hospice settings. He recently published an article that looked at the current evidence related to tools that can support family caregivers in the cancer setting. He reflects on his 2015 review, where they identified only 64 technological tools that include family caregivers. That was outside of the cancer setting, but all inclusive. So any kind of tool that was available for family caregivers, and they only found 64 in 2015. Those numbers have obviously exponentially grown. And in 2018, he discusses that there were 2 reviews done on technological tools that targeted family caregivers in cancer, and as they concluded with these reviews is that there's major gaps in our evidence. We know that these tools can be useful, we know that they are acceptable, that we know that they're feasible. However, we still don't know whether or not these tools often produce positive health outcomes. However, the evidence base is growing and we need more studies. Most of the tools currently available for family caregivers relate to education and service coordination, delivery of clinical care, caregiver-specific cognitive behavioral therapy, and peer support. And again, I just want to also note that there's a lot of work being done in terms of mobile health and innovative tools for caregivers of people with dementia. There was, again, a recent review done in 2018, and they identified 17 studies and 35 commercial apps, where the apps and the tools were specifically targeting cognitive training, screening, health and safety, leisure and socialization, and healthcare navigation. So there is a growth of tools currently available for family caregivers, and it's an exciting space to look at outcomes. And our last Jedi is Dr. Abby Robecki. She is also a social worker and a palliative care researcher from the University of Missouri. She focuses on family member experiences and narrative interventions for bereavement. She has this really cool digital storytelling intervention for bereaved family members. And she did a small qualitative study looking at the use of the digital storytelling intervention. And what she found was that family members and caregivers felt that the digital storytelling intervention allowed them to organize their thoughts and emotions about their loss. It actually encouraged their confidence and ability to discuss their feelings, and also served as a final product and a source of closure for participants. So digital storytelling might be a very unique and innovative clinical tool for facilitating meaning-making among bereaved family members. So now that I've said, oh, there's one more great area I completely forgot, is that the palliative care and patient portals. Right now, the patient portal evidence really is focusing on primary care and healthcare utilization. So are people using patient portals? How are they using it? And then does that improve specifically healthcare utilization? In the oncology space, there is a lot of literature sort of documenting particular concerns about using the patient portal for communication with patients and families. One specific example in this area is that a specific lab result that would get automatically released on a patient portal could actually be an indicator that someone's cancer or their prognosis is getting worse. And so it's really important for healthcare providers in caring for people with serious illness to be able to communicate properly via the patient portal, and to be educated that the patient portal may need differences or tweaking based on this particular setting. There's quite a rapid growth of the use of the patient portal for advanced care planning and advanced directive documentation. And there is very little known about how people are actually utilizing the patient portal at end of life, and whether or not patient portal utilization improves end of life health outcomes like symptom management, quality of life, and caregiver burden. And so some of the preliminary work that I'm doing with the PCRC pilot is to look at the utilization and the utility of patient portals at end of life. And so you're probably wondering, after saying all of these great things that people are doing, well, what's the problem with digital health? And, you know, unfortunately, there is a dark side here. And here are some of the major barriers or challenges that I think we face as digital health researchers, and barriers in terms of access. Not everyone has a mobile phone. Not everyone has broadband access, and so there's a lot of challenges, although it's intended to increase access, about who we may actually be excluding from these studies. Usability is always a concern. We have young users, old users, and we have different abilities and function abilities, and so usability can always be a complication and concern. Privacy and confidentiality of the data being shared and how it is stored is always a challenge. There is a lot of talk about technology replacing current care, and that can be really challenging for people. And so there's a lot of talk about not replacing visits, but replacing care, but rather extending care and using technology to extend care. And we'll see how that works out over the next 10 years as to how technology actually enhances care, or whether it actually starts replacing certain elements of care. There has been increases in provider burden, particularly with the reporting of patient-reported outcomes, and then providers getting notified by these patient-reported outcomes, and then their workflows are challenged by having this increased data. And how do we balance the burden that providers are feeling by getting all of this new information? Reimbursement and cost effectiveness. these technologies can be very, very expensive to create. The average mobile application costs about $425,000 from idea to launch, and that is a lot of money to invest on an intervention that we don't necessarily know it works or improves health outcomes. Interoperability is the new big word about the share of data. Once we collect this kind of information from standalone interventions and these barriers that we face in integrating them with the electronic health records are persistent, it's a major challenge. And then once they get into the electronic health record, then what does that mean for providers and their workflow? I've said this many times in terms of effectiveness, we still have limited evidence in many of these areas of whether or not these interventions improve health outcomes. And so we'll continue to grow that evidence base. Navigating regulations can be very tricky, particularly with FDA regulations around medical devices and medical apps versus lifestyle apps, and some of those challenges in terms of maintaining and meeting those regulations. And one of the other things is timelines, is that the speed in which technology moves, we are trying to study something that is constantly changing, and it can be very difficult when the newest tool is coming out while you're still studying a tool that was created 4 years ago. And so there is a misalignment in being able to build our evidence base with the current and the hottest technologies that are rolling out. So what I ask of all of you out there is to join the Rebel Alliance. Let's challenge these dark side, these challenges, and let us grow digital health and put the force back in balance. So if you are interested in becoming a digital health SIG member, we are having another in-person meeting at the PCRC meeting later this month. We will be meeting in person, but we will also be providing Zoom links so that you can join us remotely, because that's what we do in the digital health sphere, is include everyone. We're providing access. And there's also lots of funding opportunities to get engaged in this work. NINR, as well as NIA, NCI, and NIMHD are all very interested in leveraging technology to improve palliative care, to improve symptom management, as well as health disparities. So with that said, I'd love to leave enough space. I think I saw quite a few questions popping up, and so I would love to just give enough time for all of those questions.
Great, thank you so much, Dr. Portz, for an excellent presentation on what is going on with digital health in the world of palliative care, and for also highlighting the meaningful work that's happening in the digital health special interest group. We'd now like to wait just a minute for all of your questions to come in. And please have those questions come in through the Q&A feature at the bottom of your screen. I have one question from Dr. Ritchie. She's wondering for tips. She's wondering if you have any tips for navigating the rapid change in technology when studying work in this field.
Yeah, as I just mentioned, it's such a major challenge because of our sort of traditional research trajectories of identifying whether or not something is a theoretically based intervention, and then testing whether or not it's usable and whether it's acceptable and whether it's feasible, and then moving on to efficacy. By the time we know it's effective, it's already an old tool. And so some of the things that I've been increasingly interested in is actually partnering with industry partners and working with small startups and working with actual developers and trying to figure out how we can leverage the newest, hottest tools and make them applicable to our population as soon as possible. I think we're going to have to change the way that we generate our evidence. And so one of the things I do think is these academic industry partnerships.
Great, thank you. I see a couple more questions coming in. One attendant says, great talk. Any tips on bridging the different disciplines within an academic medical center? For example, the people doing AI work may not be looking at EHR. Would love to hear how people cross-pollinated palliative care into other research disciplines.
Oh, that's so great. Yeah, that is tough. I happen to be in a lab, in an mHealth specific lab, where we actually research and study multiple types of mobile solutions. And so we are constantly working with engineering. We're constantly working with the business school and computer science. We're regularly working with developers and industry partners because that is specifically our focus. And so I guess what I would recommend is maybe trying to find either a research shop or a small lab like ourselves that are working across the different partnerships that include the different disciplines, but that also include integration with your clinical setting. So whatever your innovation transfer department may look like, but make sure that there maybe is a hub of some sort that is doing that work. If you can't find a group like ourselves that work across the disciplines, sometimes it's just best to find mentors in other areas and start asking them about how your work is applicable to what they may be thinking about. Yeah, it's a lot of fun. It's a lot of fun working with a variety of people.
Great. And what are your thoughts about why there is not a lot of effectiveness evidence for health outcomes or physical outcomes with digital health? Or is digital health not the best way to address health outcomes and physical symptoms?
Yeah, there's just not a lot of evidence, generally speaking. So mHealth in some ways is fairly new in reality. I mean, it's fairly new, and we're starting to see in spaces maybe outside of palliative care that we do know that mobile health can produce positive health behaviors. So if you include that as a health outcome, we do know that it can improve positive health behaviors. We don't necessarily know if it can improve biological outcomes or other types of health outcomes. And we definitely are limited in particular populations. People of color, underserved populations, we have even less evidence. I think the problem is that it costs a lot of money to show that a tool is worth an efficacy trial. So it's a challenge of you have to spend the time to sort of prove that your health innovation is actually going to be effective, and by the time you prove that, in some ways you're behind the time to actually get to that efficacy trial. It's a timeline issue in my mind.
Thank you. And in your experience, are there certain digital health technologies or mechanisms that work best with certain palliative care populations?
I think the tool sort of depends on what you're trying to do. And so picking the tool is really dependent on the intervention that you're trying to provide. There's going to likely be interventions that can't be provided asynchronously. So you are going to have to be able to do it in person, maybe face-to-face via Zoom or a telehealth model, versus other types of information like education might be able to be provided by a mobile tool that's just sort of freestanding. So I think it really depends on the intervention itself as to which tool you're going to try and disseminate your intervention. They all come with their challenges, and they all have pluses and minuses.
Great. And we have one more question. So how do you navigate potential conflicts of interest when working with startups?
That's a really great question. And I'm going to go ahead and say I don't know, and I'm figuring that out as I go myself because I've just started working with startups, and this is definitely a new area for me as well, as to figure out conflicts of interest, but I think also ownership of particular aspects of the intervention are something that I am sort of working through right now. Of if I'm adding palliative care content to a tool that is currently available or is being created by a startup, is that tool mine or is that tool theirs? Is the content mine? Is the content theirs? And so a lot of that is actually working with legal departments, with your technology transfer offices, and trying to figure out how you do that. And unfortunately, I don't have a great answer for that.
I can see how that would be really tricky. We have just a few minutes left. If anyone else has any questions that they'd like to ask Dr. Portz while we have her on the webinar. Dr. Portz, if you don't mind just flipping to the last slide.
Yeah, absolutely.
So please send us any remaining questions. If all of our attendees do go to our website, we have 2 more webinars that are being posted for the near future. We have one actually next week, NIH grants process idea to submission with Dr. Karen Keel and Dr. Lynn Adams from NINR. We also have in March, conducting palliative care trials with persons living with dementia and their caregivers, key decisions for developing a successful trial with Dr. Ab Brody. We'll also be sending out an evaluation where we gather other topics that you might be interested in learning more about. So please take a moment to fill that out. And if there's no more questions today, I'm sure Dr. Portz would be happy to answer those via email, or you could send them directly to us at pcrc@ucdenver.edu, and we'll forward them accordingly. So thank you again to our speaker and for all of our attendees for attending. Let's see. Oh, we have one more question. How should investigators approach digital health research to not stay up to date with the advances in technology?
Can you repeat that one more time, Naomi? Sorry.
How should investigators approach digital health research to stay up to date with the advances in technology?
Yeah, again, it's such a hard balance because our timelines don't really match. I do think there is something to this industry academic partnership. I think I think we have to re-examine the way that we are traditionally looking at research. Clinical trials may not always be an option in this world, and that we may need to look at various options, cohort analyses, quasi-experimental studies to really get a better feel about the associations between digital health and health outcomes while not actually achieving the gold standard of clinical trials. Yeah, it's a tough one.
Yeah, thank you so much for that quick feedback. If there's no other questions, then I would like to thank you all again and to please fill out that questionnaire that I'll be sending momentarily. Thank you so much, Dr. Portz. Take care, everybody.
Thank you.